Elisabeth Kouaovi, and welcome to the first WHO Africa COVID-19 press briefing for 2021. Joining us from Brazzaville, the Republic of Congo, is Dr. Matshidiso Moeti, WHO Regional Director for Africa. From the University of Edinburgh in the UK is Francisca Mutapi, Professor in Global Health, Infection and Immunity. And in Abuja, Nigeria is Dr. Chikwe Iyekweazu, Director General of the Nigeria Center for Disease Control. Before I turn to Dr. Moeti, I would like to give some information, housekeeping announcements. If you have questions, and when you ask your questions, please ask your questions in the Q&A function. Mention your name and your media. And please note that we have interpretation in French and English. So use the Q&A feature for your question, mentioning your name and outlet, media outlet, and click on the globe for English or French, interpretation in English or French. Mesdames et messieurs, bienvenue à cette première session de conférence de presse pour 2020-2021 du Bureau régional de l'OMS pour l'Afrique. Nous avons avec nous de Brazzaville le Dr Matshidiso Moeti, directrice régionale de l'OMS pour l'Afrique, de l'Université d'Édimbourg au Royaume-Uni, Francisca Mutapi, professeure en santé, en infection et santé, en infectiologie, immunité et santé mondiale, et d'Abuja au Nigeria, Dr Chikwe Iyekweazu, directeur général du Centre pour la lutte contre les maladies au Nigeria. Avant de commencer, quelques questions d'intendance. Veuillez utiliser la fonction Q&A pour poser vos questions en mentionnant votre nom ainsi que le nom de votre média. Et nous avons l'interprétation en français et en anglais. Vous pouvez voir le canal français en cliquant sur le petit globe en bas de votre écran et vous verrez interprétation en français ou en anglais. Donc, vous pouvez choisir la langue de votre choix. Let's turn now to Dr. Moeti for an update on COVID-19 and a look at the new variants. Dr. Moeti, you have the floor.
Yes, thank you very much, Elizabeth. And good morning and Happy New Year to all our colleagues from the press who are joining us this morning. Bonjour, bonne année, bienvenue à tout le monde. Thank you for participating in our first COVID-19 press briefing in the year 2021. I'm very pleased to be joined in this briefing by two colleagues, friends, and leaders, a brother and sister who are working very hard on COVID-19 in Africa. First, Professor Francisca Mutapi of the University of Edinburgh, and Dr. Chikwe Iyekweazu, who is the DG of the Nigeria Center for Disease Control. So a warm welcome and Happy New Year to both of you. While in 2020, Africa was spared much of the worst of COVID-19 with relatively fewer infections and cases and deaths compared to other regions of the world, we start a new year facing new threats from the virus. With an average daily new case count of more than 25,000 in the last 14 days, Africa is experiencing a second wave, which is higher than the peak experienced last July. We know that these numbers are likely to grow as the impact of holiday season, travel, and get-togethers becomes evident. The continent has now topped 3 million cases with over 72,000 lives sadly lost. This is a stark reminder that the virus is relentless, that it still presents a manifest threat, and that our war is far from won. In addition, we are now confronted with new variants of the virus. This is not surprising, as the more the virus spreads, the higher the likelihood of mutations. However, some of these changes are concerning. Preliminary analysis finds the new variant circulating in South Africa to be more transmissible, and it appears to be driving the surge in new infections in the country and in the sub-region. Genomic sequencing has found the 501Y.V2 variant present in 3 other countries, Botswana, the Gambia, and Zambia. And frankly, we think that it could be present in more countries than that. Deeper investigations are underway to fully understand the epidemiological implications, but at present, there are no indications the new variant increases the severity of disease. There is also no conclusive evidence that it will lessen the effectiveness of COVID-19 vaccines. However, a virus that can spread more easily will of course put further strain on hospitals and health workers who are in many cases already overworked and overstretched. There's still much to learn, and you will hear more from Dr. Chikwe about research on another new variant detected in Nigeria. It's important for countries to improve routine sequencing of SARS-CoV-2 viruses on the African continent to better monitor the emergence of variants and their subsequent spread across countries. When we know how the virus has changed and fully understand the epidemiological and pathological significance of that change, we can adjust our response accordingly. WHO, together with our colleagues at the Africa CDC, have supported countries to step up genome sequencing through a network of specialized laboratories. We're also helping in shipping samples, providing laboratory supplies, as well as technical guidance and mobilizing funds. WHO is also working with a group of international scientists to coordinate research efforts, and Professor Mutapi will tell us about a new analysis of genome sequencing conducted in Africa. While we continue to increase our knowledge of COVID-19, we do know how to stop the new and the old variants of the virus. We must persist with the proven public health measures that helped to slow down the spread of the virus during the first wave, including masks and physical distancing. Finally, a top priority is ensuring Africans access COVID-19 vaccines. It's unfortunate that so far vaccine distribution has been inequitable, but this is a massive undertaking and it takes time. The COVAX facility, which is coordinated by Gavi, WHO, and CEPI, aims to provide around 600 million doses for Africa, we estimate, in 2021. We expect the first doses to arrive by the end of March, with a larger rollout by June. However, COVAX can only cover 20% of the African population, so it is really wonderful to see the African Union's efforts to secure a provisional 270 million doses by the end of 2021 are achieving success. Together, we'll deliver nearly 900 million doses for this year. We know still more is needed. WHO has developed the guidance for national deployment plans and trained all countries in key aspects of COVID vaccine development. Our monitoring shows that there's still a lot to do in terms of this preparedness, and I'd just like to emphasize that getting the vaccine doses is a very important step. Getting the vaccine into people's arms is equally important and demands a lot of work, both from countries, ourselves, and other partners. So thank you all for joining us, and I look forward to our conversation today. Thank you.
Thank you very much, Dr. Mweti. Professor Mutapi, could you tell us about the research you have conducted on new variants in Africa?
Thank you. Good morning, and it's a pleasure to be joining Dr. Moeti and Dr. Ikwema on this press conference this morning. Yes, so last week, we in TIBA published our analysis of what the SARS-CoV-2 genomes from the WHO Afro countries are telling us about the virus in Africa in BMJ Global Health. I will present a short summary of our analysis updated up to the 12th of January. So by January 12th, so earlier this week, 24 countries from the WHO Afro region had deposited a total of just under 5,000 SARS-CoV-2 sequences in the publicly available database GSAID. This represents about 1% of the publicly available sequences globally. 58% of these genomes have come from South Africa. And as Dr. Moeti said, variants of COVID-19 viruses are arising all the time. And as such, the new variant called the B1351, or as Dr. Moeti called it, 501Y-V2 variant has been identified in South Africa. It has become the dominant variant in South Africa. In Africa, as Dr. Moeti said, it has been reported in Botswana, Zambia, and the Gambia, but globally it's been reported in about 20 countries. So elsewhere it's been reported in Europe, Asia, North America, and Australia. This variant has several mutations. Most of them are in what is called the spike protein. Now, the spike protein is important because it is a protein on the surface of the virus that mediates the binding and entry into the host human cell. So without this protein, the virus would not be able to infect human cells. So obviously the questions that most people will be interested in terms of public health are on the impact of this new variant in terms of infection, diagnosis, therapeutics, and vaccine efficacy. So research is currently underway on trying to determine the impact on these, and we've looked at it from the several mutations that are on the variants in South Africa. And so far, the following is what we know. In terms of transmission, the N501 mutation, also on the spike protein, is predicted to increase the binding of the virus to the human receptor, allowing easier access and therefore transmission. So this is associated with more transmissibility. But as Dr. Moeti says, there's still no strong evidence that this affects severity of the disease. This mutation is not unique to the variant that has been observed in South Africa. It is also present in the rapidly spreading variant in the United Kingdom. In terms of PCR diagnosis, to date, none of the mutations on the variants that we've observed in the South African variant have been reported to interfere with PCR diagnosis. So we have no cause for concern at the moment on diagnosis of this variant. In terms of natural immunity and immune-derived therapeutics, such as monoclonal antibodies, one of the mutations, the E484K mutation, also in the spike protein, has been suggested to impair recognition of the virus by antibodies. But again, there's been no conclusive evidence that this may affect vaccine efficacy. And so, as Dr. Moeti says, we do not have evidence for concern at the moment. As with all variants, this requires continued monitoring. And having said that, it is clear, again, as Dr. Moeti has just indicated, that COVID-19 cases and deaths in Africa are rising. It is very important that we continue to increase sequencing capacity in Africa so that we can know a lot more about the variants that are circulating in the country, in the countries and in the continent as a whole. This is what we in TIBA have been doing for the past 4 years, working with colleagues to capacitate the sequencing of local viruses by local organizations within Africa. So I'd like to end by reminding a lot of us of the lessons that we have learned from previous experiences with epidemics in Africa, which is that we need to know our epidemic in order to know our response. Thank you.
Thank you very much, Professor Mutapi, for this update. Dr. Chikwe, I'm turning to you. Dr. Chikwe Hiekweazu, can you tell us about the investigation into the new variant in Nigeria?
Thank you, Elizabeth. And firstly, to thank my dear sister and colleague, Madame Moeti, for kindly inviting me to join your first press briefing for the year. I'm really grateful to WHO, always at global, regional, and country levels for your coordination and your support, really from the beginning of the pandemic. But thank you too to Professor Mutapi for your insightful briefing on findings from African countries, variants found in 23 African countries. I will focus my initial discussion on our findings in Nigeria and response activities here in the country. Following the report in the UK on the 19th of December, describing preliminary genomic characterization of an emergent SARS-CoV-2 lineage, the B1.1.7, our partners at the Africa Center for Excellence for Genomics of Infectious Diseases did a rapid analysis of samples that we had collectively collected here at the center and done genomic sequencing on. ISGID identified 2 SARS-CoV sequences that form an emerging variant called P681H variant in Nigeria that shares one mutation with the UKB1.1.7 lineage. However, this variant does not share any of the 22 other lineage defining mutations of B117. These cases of P681H variant in Nigeria were found in 2 samples collected on the 3rd of August and the 9th of October. Now, the background to this is that the work done by ISGID and ourselves shows that there are 18 different lineages detected in Nigeria so far since the beginning of the outbreak. And we do not have any evidence to indicate that this P681H variant or any other variant currently circulating in Nigeria is associated with increased transmission. So that the emergence of new variants in of themselves is not interesting and is not news. What is news is if one of those variants has been shown to be associated or correlates with an increase in transmission, increase in variability, resistance to vaccination, or any other outcome indicator. So the emergence of new variants in of themselves are really not interesting. Viruses mutate all the time, and we will always have new variants emerging. While we do have genomic surveillance in a few centers in Nigeria, the relative difference in scale in Nigeria versus the UK and even South Africa may obviously imply a reduced likelihood to detect such changes when they do happen. We are currently in the process of sequencing more samples from the recent surge of cases in Nigeria in order to analyze, firstly, for changes in circulating viruses in Nigeria, but also specifically looking for those variants of interest, which is what they're now called the variants of interest circulating in South Africa and in the UK that have already been shown to be associated with increased transmission. So our ongoing efforts in sequencing have 2 objectives. One is to identify if there's any variant that is associated with any change in an outcome, either in transmission, severity, mortality, or any other. And secondly, to specifically look for the variants of interest already identified in the UK and South Africa to be associated with these changes in transmission. So in as much as the full effect of this mutation and others are still being studied, the importance of a robust genomic surveillance system cannot be overemphasized. And as we identify and report changes in the genomes of pathogens such as SARS-CoV-2 that are of public health interest, we really must learn from efforts in South Africa specifically, where they have both done sequencing to scale, but also over time periods, because it's only when you do this over time that you can demonstrate change in the prevalence of one sequence, one variant over another. And it's only when you can do that and link that to epidemiological data that you can make any conclusions on changes in transmission, ability, in severity, and all of that. So finally, on the 12th of January, we joined a WHO convened meeting to define research priorities for emerging variants of SARS-CoV-2. We remain grateful for WHO's leadership in coordinating scientists and governments to understand what we know, what we do not know, and how to collaborate for finding solutions in our countries. We urge all countries to work in solidarity with WHO to ensure that we are developing solutions together. No country is safe until every country is safe, and we cannot learn about new variants or their impact by working within our national borders. So we have to scale our ability for genomic surveillance, but we will only learn important lessons if we do this together and if we scale together around the world. Thanks.
Thank you very much, Dr. Chikwe Iekweazu, for this update. Now that we've heard from our panelists, your turn to ask questions, ladies and gentlemen from the press. To do this, please use the question feature, question and answer feature, and in the Zoom application at the bottom of your screen. And please remember that you will need to provide your name and the news organizations you represent to have your question asked. And please bear with us. We will allow only one question per journalist due to the number of questions you receive. So without too much ado, I will turn to the first question to Dr. Moeti or Dr. Chikwe. And the question is from Esther Nakazi from BMJ. Does Africa have the capacity to sequence and know which variants are circulating on the continent? If so, how many variants so far are circulating? What variants do we know for sure are in Africa? Dr. Moeti or Dr. Chikwe?
Yes, thank you very much for that question. I will start and then Chikwe may expand. Let me say we also have a colleague on the line who is going to supplement on the issues of the vaccine sequencing. She's one of our team of virology and laboratory experts. So I think that, I mean, certainly we can say without any doubt that not every African country has the capacity to do gene sequencing. That's why it was important to identify, working with the Africa CDC, a network of laboratories that do have this capacity, and the work that we've been doing in linking them with ministries of health, with the other countries, supporting not only the transportation of specimens, but also starting to work with them to build this capacity. So I think there's no doubt the capacity is not all there, but what's most important, and I think Chikwe said it very well, is to work beyond the borders of individual countries to link up and to maximize the capacities that are there. My colleague, Nixie Gumede, has very much been involved in this work of networking the centers of excellence that exist with the rest of the countries so that working together, we can pull together this capacity. So Chikwe, over to you to see what you have to add. And then I think we can also ask Nixie to respond to the rest of this question.
Thank you very much, Madam. I think, definitely Nigeria and many countries do have the capacity to sequence, but it's not sufficient. It's asking, do we have labs that can test? Testing capacity is different from surveillance, where you have to test a specific number of samples from a defined population over time. It's the same thing with sequencing. We do have the capacity to sequence in Nigeria and in many other countries, but that's different from genomic surveillance, where you're sequencing a defined number of viruses collected from a defined population at defined intervals over time. Now, that really is where we need to build that capacity. South Africa has that capacity and has demonstrated its utility in the emergence of a new virus such as this. We are building up that capacity. We're not there yet. It's really the role of sequencing in surveillance has grown so much over the last 5 to 10 years, but it still requires significant investment, significant knowledge, capabilities that we're all building up very rapidly. But really the importance of this will continue to grow over the next few years. So we will continue to work with our partners in WHO and everyone else interested to build up genomic surveillance on our continent.
Thank you very much, Dr. Moeti, Dr. Chikwe. Let's go to Elizabeth Merab. She's online. Elizabeth Merab, are you online?
Yes, I am. Hi, Elizabeth. Thank you for the opportunity. My question is about the immunity that is conferred either from infection or getting the vaccine. Do we have any information on how long this immunity lasts? Thank you.
Maybe Professor Mutapi will take that.
Great, thank you. The short answer is no, we don't have any idea how long the immunity lasts. However, the aim is to get at least 6 months of protection. And with vaccination, we aim at least for anything between months and years. And this has been the information that has been put out there by the colleagues developing vaccines. A lot of this information will become known in what we call phase 4 clinical trials after the vaccine has been deployed. And that is why it is really important that we continue the surveillance and monitoring of the impact of vaccination, not just on the side effects, but also to learn a bit more on the length of protection and the level of protection in the people. So the phase 4 clinical trials will be really, really critical for after the deployment of these vaccines. Thank you.
Thank you very much. Simon Allison, is Simon Allison online from the continent, Mail and the Guardian? Simon Allison, Simon, are you online? No?
Yes, I'm here.
Please go ahead with your question.
Hi, this is Simon Allison from The Continent and the Mail and Guardian. A question for Dr. Moeti. When the COVAX vaccines do become available to African countries, what is the distribution and rollout strategy? Who gets them first? How will all that be decided? And then to Dr. Ihekweazu, where does Nigeria stand at the moment in terms of acquiring and rolling out vaccines? Thank you very much to all the panelists for the information today as well.
Okay, thank you very much for that question about the rollout, the prioritization. It's a very important matter that countries are actually working on now as we speak. So the countries have begun their work of planning and getting ready, and including defining the priority groups that will initially receive the vaccines when they become available. So this is work that's still ongoing. Clearly, as is the case in all settings, the groups that are considered the highest priorities are the frontline workers, particularly the frontline healthcare workers. And we've seen in some of the countries significant numbers and even deaths among healthcare workers. And then other highest vulnerability groups, including people of a certain age, people in the older age groups, people with pre-existing conditions that make them susceptible and vulnerable to complications and to severe forms of the disease. So at the moment, WHO has provided some guidance on this process of prioritization, and really is for each country to determine within its own context how to carry out this, this prioritization, the sequencing of who will receive the vaccines. Clearly, in most cases, the virus has been circulating most intensely in urban areas in African countries. It entered, as we know from international travelers, in the capital cities more often than not. It has spread in many of the countries more to some degree to the rural areas, but we still see, if we look at the distribution, that it is very much circulating in urban areas. So I'm sure in terms of some of that geographic initial deployment of the vaccine, in order to start to contain and make an impact on the situation, it'll be starting in the urban areas. It'll be looking at frontline healthcare workers, most vulnerable populations, and then spreading to other groups, including, if you like, frontline workers in other sectors who are also relatively exposed.
Okay, so thanks, Simon. In Nigeria, everyone is working very hard on this at the moment. The efforts are led by a sister agency, the National Primary Healthcare Development Agency, that is responsible for the distribution, the management of everything concerning vaccination in Nigeria. I must say, in a way, unfortunately, we've had, but fortunately in this case, we've had a lot of experience with vaccination campaigns, given the intensity of the work we did around polio, the vaccine campaigns we've had to do for yellow fever. Yes, the target populations might be a little bit different, but we understand very well the steps required, the micro planning, the planning for logistics, the coordination among the states. So we're going to leverage on all of that experience. So right now, MPHCDA is leading on what Madame Moeti just described, defining our priority populations. Healthcare workers are the obvious ones, but then the next ones, also defining, sometimes in Africa, even if you know what your priority populations are, we don't necessarily have the population registers easily available. So we are walking through different methods and mechanisms to identify who these people are and where they are. And also thinking, like Madame said, about, how do we balance issues like incidents in certain states and cities versus equitable access across a big country like Nigeria. So these are difficult questions, but this is on everyone's mind right now as we work very hard. Firstly, also to mobilize local resources. We're a big champion and we really are counting on COVAX to come through for the continent. We think it's an excellent way to do global health, and global health security is a great example in solidarity around the world. But now we've got to push that it delivers and delivers on a timely basis. And we begin to see pictures of the first Africans being vaccinated here on the African continent. I think that will bring a lot more hope and reinvigorate a lot of the work that we're doing in response to the pandemic.
Thank you very much, Dr. Chikwe. Je me tourne vers Sophie Bouillon. Sophie Bouillon from AFP Lagos. Are you alive? Are you online?
Yes, I'm here. Can you hear me?
Sure.
Yes, good morning to all. Thanks for the opportunity. Yes, I have two quick questions. The first one is, how many labs exactly in Africa that can do the sequencing of the virus? I read 6, and where are they? And also, Dr. Chikwe, how come the Nigerian authorities have not communicated more on this new variant of the virus, and hardly have not communicated? How do we explain this? Thank you very much.
So if you permit, Elizabeth, I'll ask Nixie to answer the first question about how many labs, because she's very much involved in this lab network.
Sure, Nixie.
Thank you so much. Thank you, Madam, and thank you, Dr. Moeti. Just to give a brief information regarding the network that has been constructed, we have a total of about 12 laboratories, and then this has been categorized based on the specialized laboratories. As Dr. Chikwe mentioned before, that is not only a lab that has to produce the sequencing data, but we need to also to know that if the lab is capable of also making forward or further do the analysis using the bioinformatic tools. So we've got labs that are based on that category, a specialized COVID sequencing laboratory, which one is based in Nigeria, that is ACEGIT, as Dr. Chikwe mentioned. And we've got 2 of these laboratories based in South Africa. One is CRISP, that has been giving us further information related to the new variant that is circulating in South Africa. And we've got another one, which is a South African National Bioinformatics, which is more of a bioinformatics center, also based in South Africa. But looking at the overall representation of these laboratories in Africa, we've got one in Senegal, that is in Dakar. We've got one in Ghana. We've got also Africa and Nigeria CDC, where Dr. Chikwe is based. And then we've got one in DRC and Gabon, Uganda, Kenya, and also NICD, which is National Institute for Communicable Diseases here in South Africa. So overall, we've got about 12 representation of these laboratories all over the WHO Africa region. And in addition to that, as you know, that we are working very closely with Africa CDC, we've got also another representation of these laboratories in Morocco that are catering mostly of the northern countries in the continent. But apart from that, as Prof. Francisca has mentioned earlier on, that the African region has produced close to more than 5,000 sequencing data on the bank that is sort of like globally accessible. And then that means that over and above the 12 laboratories that are part of the network, we even got other countries which are not part of the network, but they're busy producing the sequencing data. And all in all, in the African region, we've got about 25 countries that have contributed to that number of more than 5,000 of the sequencing data. I think that's all from this clarification regarding the network. Thank you to you, Madam.
Thank you very much. Thank you, Nixie. Let's turn to RFI, Bineta. I think she's not live, but I'll read out the question in French. Please listen to the interpretation in English. Bineta has asked, comment faites-vous face à la seconde vague en cours? Est-ce que les capacités de dépistage suffisent? And I will turn to Dr. Ngoy. Dr. Ngoy, vous êtes en ligne?
Oui, je suis en ligne.
Voilà. Bonjour, docteur.
Bonjour.
Meilleurs vœux, comment allez-vous?
Merci, je vais bien. Meilleurs vœux à vous aussi.
Donc, la question de Bineta de RFI est de savoir comment est-ce que le continent fait face à la seconde vague qui est en cours et est-ce que les capacités de dépistage sur le continent suffisent?
OK, merci beaucoup pour la question. Merci beaucoup, Bineta de RFI. D'abord, je voudrais faire juste une petite clarification puisqu'il y a plusieurs questions qui circulent dans les médias qui lient cette deuxième vague à la nouvelle variante, en particulier dans les pays de l'Afrique australe. Il faut tout de suite dire que, comme a dit le professeur Moutapi, qu'il y a suggestion que cette nouvelle variante puisse avoir une plus grande transmissibilité. Mais si nous avons une augmentation du nombre de cas dans nos pays, ça signifie une chose. Que ce soit la nouvelle variante ou que ce soit l'ancienne variante ou que ce soit les autres, ça juste signifie que nous n'avons pas pu réussir à casser la chaîne de transmission. C'est ça que ça veut dire. Alors, que ce soit la nouvelle variante, que ce soit les anciennes variantes, ce que nous disons, c'est que les mesures de prévention n'ont pas changé et que ce que nous devons faire dans nos pays, ou même ce que nous préconisons ou conseillons à nos pays, c'est de renforcer ces mesures de prévention. Et c'est d'autant plus que, surtout s'il s'agit de la variante avec une plus grande transmissibilité. Ça veut dire que maintenant, nous devons même renforcer les mesures plus qu'avant. Ça veut dire plus que la chance de transmettre est plus grande et donc il faut tenir à ces mesures que nous avons édictées depuis longtemps qui constituent à porter les masques, le port des masques en tout lieu, surtout dans les lieux publics, le lavage des mains et bien sûr la distanciation sociale. Voilà ce que nous préconisons pour nos pays et ce que nos communautés surtout doivent prendre et renforcer encore plus davantage à ce stade.
Merci beaucoup, Dr. Ngoy. Before I go to the next, yes? Sorry.
Oui, non, je voulais demander à Dr. Ngoy s'il peut dire quelque chose concernant la capacité de dépistage. Parce que je suis d'accord avec lui que nous devons vraiment, comme on dit, rappeler, réencourager la population de continuer avec les mesures de la prévention. Nous notons une certaine fatigue. Nous devons dire que ça fait 1 an quand même que les gens sont demandés de porter le masque, garder la distance. Ça commence à être difficile. Donc, nous devons renforcer la communication, encourager, appuyer, que tout le monde arrive à continuer avec ces mesures. Mais le dépistage aussi doit continuer d'être renforcé et surtout avoir des résultats à temps pour prendre des actions de la santé publique. Donc, Dr. Ngoy, est-ce que vous pouvez dire, est-ce que la capacité de dépistage s'est améliorée? Est-ce que c'est assez, tout ça?
Merci beaucoup, madame. C'est effectivement une question très importante puisque, comme nous le disons aussi, la stratégie se résume à détecter, identifier, isoler et puis faire le suivi des contacts. Et donc, la détection et la capacité de tester, elle est très importante dans la stratégie pour gérer cette épidémie ou cette pandémie dans nos pays. C'est vrai que dans la plupart de nos pays, comme a dit le Dr Chico, il faut différencier la capacité de tester. Nous avons des laboratoires qui testent, mais est-ce qu'ils testent suffisamment? C'est ça la question. Et la réponse claire, c'est que non. Nous avons la plupart de nos pays qui testent moins de 10 ou même moins de 5 par 10 000 habitants. C'est très peu. Et on voit même dans les pays qui ont cette capacité à tester moindre, qui ont même ce que nous appelons les taux de positivité très élevés, ce qui montre encore qu'il y a une faiblesse de tester dans nos pays. Au fait, il faut aussi signaler ici que la faiblesse de tester, ce n'est pas seulement la capacité ou l'existence du laboratoire, c'est aussi la stratégie qui est utilisée par les pays. Parce que nous commençons à voir que dans certains pays, on commence à privilégier le test pour les voyageurs, au détriment des tests pour détecter qui est infecté, pour prendre des mesures de santé publique, des mesures de prévention. Donc, c'est là aussi que nous devons renforcer le message avec nos pays, c'est qu'il faut continuer à tester, non seulement tester pour le voyageur, mais tester pour la détection des cas et tester pour la détection des cas pour le suivi et pour les mesures de prévention. Maintenant, c'est vrai aussi que la plupart de nos pays, ils ont des problèmes de réactifs. On dit en anglais des reagents. Ils ont des problèmes de réactifs qui souvent, ils ont des ruptures de stock. Maintenant, ce que nous préconisons aussi, c'est qu'en plus du PCR, c'est que le pays puisse introduire dans leur stratégie de testing l'utilisation de tests rapides basés sur les antigènes. Et je crois que j'ai pu voir une question que le Nigeria aurait déjà commencé à introduire ce testing. Ceci pour augmenter le nombre de personnes qui testent. Et ce n'est pas seulement pour que nous puissions connaître qui est testé, mais pour que nous puissions faire le suivi des mesures de prévention vis-à-vis des personnes qui sont testées dans la communauté. Voici ce qui est important. Mais pour le moment, les niveaux de tests dans la plupart de nos pays, à part comme les pays comme l'Afrique du Sud et certains pays comme les Seychelles, le niveau de testing dans nos pays est encore insuffisant.
Merci, Dr. Ngoy. I will turn now to Paul Adepo from the Lancet. Paul, are you online? Please ask only one question. I know you have many questions, but please ask only one question in the interest of time. And tell us who your question is directed to.
Okay, thank you very much. My question is directed to Dr. Chikwe and Dr. Moeti. For Dr. Chikwe, Africa CDC recently revealed that Nigeria has recorded a surge in number of deaths. While the CFR ratio hovers around 1.3%, the death rate has increased by 30% in the last epidemiologic week. So what is responsible for this surge and what is being done to ensure equitable access to oxygen so that patients that need it can survive? And is Nigeria accessing COVID-19 vaccine outside COVAX platform? And this is where Dr. Moeti comes in. What is the WHO's position on other Africans attempting to access COVID-19 vaccine outside of the COVAX platform? Thank you.
I think we agreed on one question, Paul. Which one would you prioritize? Let's give the floor to Dr. Chikwe, and we see if we can continue with Dr. Moeti, because we have many
the question.
Thank you, Paul. Firstly, there was a question earlier that we missed. The relevance of the quote-unquote new strain in Nigeria and why we haven't said anything about it. Like I said, new strains of viruses are not news. So there's nothing to report. Viruses mutate all the time. It's only news when it's associated with an increase in transmission, increase in severity. So that's really why we haven't announced anything. There's really nothing to announce until we can demonstrate either that there's a new strain associated with increase in transmission, or we have found one of the strains that have already been demonstrated to be associated with transmission here in Nigeria. So there was nothing to announce, and that's why we didn't announce anything. Paul, on your question on surge in deaths, you know, there's definitely, this is a numbers game. We haven't seen that any new strain of the virus is associated with an increased severity or increased outcome of mortality. So what we've seen that this remains steady. Therefore, as we see more cases, we will see more deaths. this is almost inevitable, because the more cases you have, the more deaths you will have because of all sorts of demographical issues in terms of who is infected most in the population. We've obviously, every country in the world, Nigeria inclusive, is really struggling with access to oxygen. We have ramped up production of oxygen here using both publicly available methods, but also bringing in the private sector. We have a very strong and vibrant private sector in Nigeria, so we've mobilized the private sector to support government's work around this, at primarily in the states with higher incidence in Lagos, FCT, Kaduna. We'll keep working on this. So yes, we understand very much that really the biggest indicator for where we are on this outbreak is not really the number of cases. The biggest indicator that will put us under pressure is the number of deaths. So we must keep working very hard to save as many people as we possibly can, given the limitations that are clear to everyone on the deficits in our health systems on the African continent.
Thank you, Dr. Chikwe. Let me turn to Dayo. Dayo.
If you,
oh, sorry, Dr. Moeti, please come in.
If you permit, I would like to respond to the second question about what is the COVAX point of view, or WHO's point of view about countries getting vaccine outside of the COVAX, because I think it is an important point, if you will permit. So, of course, the COVAX has announced from the very beginning its aim as far as supporting low income and low middle income countries to have around, or at least to cover at least 20% of their population. So it's clear that it has very much been our wish. And as I said in my opening statement, we are very pleased, we're really excited that out of their own efforts, African governments coordinated around the African Union are working very hard and have made the first step to the first success to acquire vaccines outside of the COVAX facility. So our expectation, and in our conversation with our colleagues in the African Union and Africa CDC, has been very much to work in complementary fashion. So we are keen for our countries to get all the vaccines that they can get. What we would, of course, like is that these should be vaccines that have been looked at, reviewed, the data has been availed in terms of their efficacy and in terms of their safety. WHO is carrying out the role of emergency use licensing of some of the vaccines that are being produced, that necessitates the manufacturers and the producers sharing data with the team in WHO headquarters that carries out this licensing. So to answer, we are very keen for countries to try every opportunity to look in every way to mobilize the additional resources outside of the COVAX and to secure additional supplies, because the important thing is to reach a coverage of the population that will then stop the circulation of the virus. So again, we'd like to congratulate our colleagues in the African Union for the efforts that they've made. WHO's work includes helping in terms of the quality assurance. We have a pre-qualification team, and we are working to carry out the emergency use licensing that can now then assure our countries that these are vaccines of good quality. They should go ahead and get them. I just wanted to make that point. Thank you.
Thank you very much for this very important point, Dr. Moeti. Let me turn to Dayo. Dayo, are you online? You can ask your question live if you're online, Dayo. And please tell us who you are directing your question to. Dayo. Dayo, are you there? Please, are you muted? Please unmute yourself. Okay, see, if Dayo is not there, let me turn to Sarah Gerving of DEVEX. Sarah, you can activate your mic and ask your question, please. And please tell us who your question is addressed to. Sarah? So, no Dayo and no Sarah. Sarah? Sajerving or Dayo? Okay, if none of them, I can read the question by Eniola Akin Kuotu. This question is for Dr. Chikwe. Hello, my name is Eniola from Punch, a newspaper in Nigeria. So this is a question for you, Dr. Chikwe. The Nigerian government is planning to hold a National Youth Service Course program next week, which will attract at least 6,000 youth nationwide in orientation camps. And this is despite an advisory by the Vice President's Economic Sustainability Committee that such camps should be shut for 2 years. Wouldn't this boost the spread of COVID-19, even as Nigerians continue to gather at NIMC registration centers? Dr. Chikwe?
So thank you. I think this is actually a question for us in Nigeria, but I'll still answer. You know, from the beginning of this outbreak, every country has had to make very hard decisions. And if you're not in that decision-making seat, you probably don't understand how hard this is. Do you stop a child from going to school for 1 year, or do you manage this outbreak and close schools? We cannot afford to close schools, universities, close everywhere, working places, close ports. It's just not possible. We are confronted with a situation in Nigeria and in any other African country that we will start having access to vaccines over the next few years, over the next few months, right? But even if we get to 20, 40% coverage, it will take another 2 years to get to the levels of coverage that we need to stop everything else, all the non-pharmaceutical interventions that we're living with. So we've got to find a way to continue moving forward with certain aspects of daily life in a controlled way, mitigating risks as much as possible. So to your specific question on NYSC camps, we have 3 streams of these. We've had the first 2 streams. We've successfully mitigated the impact of these camps on transmission by administrating rapid diagnostic tests on every single person coming into these camps before they get into the camps, as well as instituting very strict IPC measures within the camps. Therefore, in working with our NYSC colleagues, we are confident that we can mitigate the risk of accelerated transmission within these camps by strengthening the measures that we've already carried out. And it is a similar discussion that will happen with any other sector. This is what we've done with airports before we reopened airports for flights. It's what we did with schools before we reopened schools. And now schools were shut again, but there are discussions, universities, ports. So every part of the economy will have to find a way of mitigating transmission and managing the impact of the virus, but we cannot afford to stop everything while waiting to get this outbreak under control. I don't know if Prof wants to add to that from your reading and science from around the world and the UK and other countries in the world that are struggling with similar decisions.
Thank you for that. Just to reiterate what you said in a slightly different way, it's about managing risks. And it's about ensuring that the long-term impacts of the current mitigation strategies are not more harmful than what we're trying to actually prevent in terms of COVID. So every country, yes, we follow the guidance that we've been given, in collaboration with colleagues in WHO, Afro, and at national level. But you're looking at the risk of a COVID infection, a COVID death, versus the impact on the economy, the long-term impact on children not going to school, children being exposed to other harms such as pregnancies at home, child abuse at home. So it's about managing risks. And every country, as you say, you sit down at the table and you discuss what's the best way forward while we're reducing the risk of COVID infection, COVID deaths, of carrying on with life as best as we can to mitigate the future harms of our current control measures. I'll stop there. Thank you.
Thank you very much. Thank you very much. I will try to get Dayo online. Is Dayo there now? Dayo, if not, I can read out the question. Dayo asked the following question. What role is the World Health Organization playing to ensure that each country in the world, especially in Africa, gets the WHO-approved vaccine? And I think this question goes to Dr. Moeti.
Yes, okay, thank you. I guess we didn't say in detail the role that WHO is playing. I think we're very much playing an advocacy role in partnership with some key players at the global level, as well as at the regional and country levels, to help African countries have access to vaccines. I mentioned this COVAX facility, which is part of what is called the ACT Accelerator platform. So WHO led, initiated with some partners, with Gavi, with CEPI, with some member states, a platform for promoting, working towards and supporting equitable access to the key tools to respond to the pandemic. So that includes several things, therapeutics, testing kits, and it also very much includes vaccines within a subset of this platform called the COVAX, in which Gavi is playing a very important role. And so is CEPI, a coalition on epidemic preparedness and tools within epidemic preparedness. So we have worked together to do several things, particularly targeting low-income countries, middle-income countries, but also some upper income countries have been part of this partnership. It's basically a way to pool efforts and resources, pool the financing and carry out the negotiation, the discussion with vaccine manufacturers, and even some of the financing of some of the research to develop some of the vaccines together, so that we make sure that the poorest countries who are virtually almost left behind when new tools come on board are not left behind to the extent that we are used to in the past. And when you pool resources, it means that you constitute a big group in terms of the volumes that you are looking for when you are competing on the global market, which has been a very difficult situation with all of the COVID-19 key supplies. So what we have played this role of mobilizing partnerships, working with Gavi, a partner that we're very much accustomed to working with CEPI as well, a key partner we worked with, working with member states, both the upper income member states who have contributed and are subsidizing access for the lower income countries. And then of course, as I said earlier, being in discussions with groups like the African Union and Africa CDC to make sure that we are complementing each other in terms of what we're doing to help our countries to obtain supplies of the vaccines. So this is what we have done. Of course, we've also, in addition to helping with vaccine access, we played an important role in helping the countries with their preparedness, starting to look at their planning, looking at the logistics. I think Chikwe mentioned that very much. We are used to being a key partner to countries when they carry out vaccine campaigns, their routine vaccine services for children under 5. We're playing this role as well. We have monitored and tried to tell countries how ready they are in a way to remind them about some of the things that need to be carried out in terms of readiness. We're working with the regulatory bodies on the continent, because for each country to start to use the vaccine, its own regulatory authority needs to license the use of this vaccine. So we have established a coalition, a network of regulatory bodies at the regional level, and we're helping them to work together so that we speed up this regulatory agreement by countries, so it does not become a delaying factor in countries actually being able to start using the vaccine.
Thank you very much, Dr. Moeti, for this very comprehensive answer. Let me turn to Reuters. Alex Winning, are you online? Alex Winning at the Reuters news agency.
Can you hear me?
Yes. Can you
Excellent. Thank
ask
you.
your question? Who is your question directed to?
To Dr. Moeti, please.
Okay,
So
thank you. Go ahead.
Thank you. The question is that Dr. Moeti said that the first COVAX doses could arrive in Africa in March. Could you say which African countries could receive these first COVAX doses in March? Is South Africa one of the countries, and what criteria, since the WHO is co-leading the COVAX facility, what criteria are being used to decide which African countries will get vaccines first? Thank you.
Yes, that's a very important question. And it's something on which our colleagues who are leading on the COVAX work are actually working right now. I think the aim is to minimize to the extent possible countries being left behind because, the principle around the COVAX is very much around equity. So I'm not able to tell you which will be the first countries, but the aim is to make sure that we have a kind of equal, to the extent possible, based partly on country readiness, which is why I was emphasizing its importance. So our aim is to make sure that all countries start to receive some of the vaccines that they need at the same time so that countries are not left behind. And therefore, we emphasize very much the importance of getting on with the preparedness, making sure that countries invest all the effort that's needed for that. Clearly, South Africa is a country with a special situation on the African continent. It's the worst affected country right now. If we look at the current situation, in terms of new cases, about 75% of the new cases that are being reported. So it would clearly be among the first countries to receive the vaccine. What we want to avoid in an effort to address this equity is vaccine sitting unutilized while countries are getting ready. So again, just to emphasize the hard work that's needed in the next period in terms of gearing up the preparedness of countries.
Thank you very much. I would like to I ask you to bear with us. We're going to go on for 10 more minutes in view of the importance of the subject and because there is so much interest, and I hope our panelists are okay with that. And if so, I will proceed with David Mulgray from Radio International for Dr. Moeti. Who in Africa authorizes vaccines for use and how is it done? Do all countries have the capacity or do they contract that out to WHO? Dr. Moeti.
Okay, and as I said, it's first and foremost, it's national regulatory authorities. So each country has a body whose role it is to authorize the importation and licensing for use of all sorts of medical products, drugs, medical devices, and they are the ultimate authority that decides that this can come into a country and be used or not. And as I said, the capacity is very different in different countries. And in the past, we have seen that this is a step that can engender some delay in getting products into countries. WHO offers a service of, as a global technical agency, of undertaking what we call pre-qualification of producers and manufacturers of global health goods, and being able to assure countries that we've looked at this vaccine that's being produced by this pharmaceutical company and this producer, and it meets all the requirements in terms of quality, in terms of safety, in terms of efficacy based on the data that's shared with WHO. And this becomes the basis in many cases for the regulatory authorities in countries then to accept this WHO assessment and to use that as the basis for their own approval of products to be used. So as I said, the pooling of efforts, working together, pooling of technical expertise, using common, if you like, standards to assess vaccines is going to be extremely important. And we're already working with the network of regulatory authorities that are working together in the region to pool resources, speed up the process, and work collaboratively on this.
Thank you very much. Thank you very much, Dr. Moeti. Let me turn to Tamar Khan from Business Day. Tamar Khan is asking to Professor Mutapi, what is your assessment of the threat the new variant identified in South Africa poses to A, vaccine efficacy, and B, antibody treatments? Professor Mutapi, please.
Thank you. So I like this question because I am an immunoepidemiologist by training, so I spend a lot of time looking at the way antibody responses behave. So the good news is there are more than one vaccine out there. So we've heard about the Pfizer vaccine, we've heard about the Oxford vaccine, we've heard about Moderna. I think there's an awful lot more out there. And an even better thing is that the vaccines are not all directed at a single target on the protein. So if we look at the Oxford vaccine, it is a vaccine that is a recombinant protein of the spike protein. So the spike protein is a large protein. If we look at the Pfizer protein and the Moderna vaccines, they're also directed against the spike protein, but they are messenger RNA vaccines. In China, we know there are an awful lot of vaccines, I think about 3 or 4 that are directed against the inactivated virus. The virus has a total of 29 proteins. So by using the whole virus, you can target any of those 29 proteins when they are expressed. So what this means is if you have a variant of the virus that has a single mutation or a few mutations in the spike protein, other regions of the spike protein can still be recognized by your immune system. Okay, you will not mount 100% response to the whole protein. Maybe it might be 97. So it might be slightly reduced, but it won't be obliterated. So that's the first thing to remember, that varied targets, and you can ensure that the heterogeneous immune responses in the human populations will be able to pick up one of those. The second thing is particularly the Oxford vaccine and the Pfizer vaccine, you can actually modify those to be specific for the new variant, any new variant actually, because it's a case of just putting that vaccine strain's RNA or recombinant protein into the vector or onto the nanoparticle for the delivery of the vaccine. So it's not the end of the world that we've got variants. Even if you were using the same variant and you put it in different people, you would still have a heterogeneous immune response. So I think at the moment, this is not our biggest worry. I will stop there. Thank you.
Thank you very much. I think I'm afraid we will have to wrap up at this stage, and I would like each of our panelists to wrap up, give us concluding remarks, and maybe I could ask Dr. Moeti to include in a last final message a question by Neil Munshi, the Financial Times, who is asking how severe is the second wave in Africa and what is driving it. So Dr. Moeti, if you kindly give us your final message and include in your response the answer to this question. And I will ask the other panelists to get ready also for their final messages. Thank you, Dr. Moeti.
Okay, thank you. Thanks very much. First, the question of how severe is the second wave of the, if you like, which actually was starting even before people started going home for Christmas in some countries. I think we have seen in a number of countries, in South Africa, of course, which has experienced the most severe second wave, but also in a number of Southern African countries, in a number of other countries in other parts of the region, an upsurge in cases due to the second wave of the disease. I think it's certainly overall more severe than the peak that we saw in the region in July. So I think if we take an overall continental and regional approach, it's a significant increase in the number of cases. We are also seeing in some of the countries an increase in the deaths, which might be attributed to the systems getting overwhelmed and therefore the quality of care and the type of care available to people being compromised. I think what we just have to understand, I can only repeat what my colleague said, is that there is a need to reinvigorate the response at different levels, at the level very much of individuals, of communities, but also to benefit from the years' experience that we've had and sharpen the public health response, the most important aspects of it, and go back to those basic principles of we need to be looking for cases and contacts, we need to be testing and getting the results as fast as possible, and we need to be more consistent about isolating and breaking the chain of infection from people who are infected. So I do think we'll go through a difficult month or so as we see the surge from the festive season. We have been talking to countries for them to anticipate this and to prepare to reinforce their response to this, and at the same time as preparing for the vaccine. And then if I can just say a word in conclusion on the matter of variants, I think that's been said very eloquently by my two co-panelists, Francisca and Chikwe, who are very much experts in this area. As Chikwe said, a new variant is not news unless it's showing characteristics that are problematic to the response. So my message on this is that we will follow up on this, but we need not to panic, because there are new variants emerging. We need to apply the science. We need to keep on reinforcing the public health responses. And of course, adjust where there is evidence about a particular danger or risk that's posed by a new variant. And then on the vaccine, I would very much like to echo what my colleagues have said. We have the possibilities for this vaccine. It's something that's extremely important for the response. It's not going to be a magic bullet. It's not going to stop the pandemic at once. And we need to combine the rolling out of the vaccine and in a way manage our disappointment as we see wealthier regions and countries starting to vaccinate while we wait a few weeks to a couple of months. I believe strongly that the waiting gives us the opportunity to really reinforce our readiness. And I hope that by the time the vaccines are landing, our countries will be ready. We will be there to support them so that we move very strongly in making these vaccines available to the highest priority people in terms of vulnerability, while we continue with the public health measures until such time as the coverage is sufficient for us to take life back to a kind of new normal. Which is very important for the economies and for families and for people's livelihoods in the region. So thank you very much. I will stop there.
Thank you very much, Dr. Moeti, for these words of wisdom and very reassuring message. Dr. Mutapi, Professor Mutapi, would you like to give us your final message?
Thank you very much. I do not want to dilute any of the really strong and positive messages that Dr. Moeti has just said. So I'm not going to say anything more about the strains or anything. The only thing I'm going to say, because very few people get the opportunity to say this, is to really express my gratitude and continued support to Dr. Moeti and her team at WHO Afro. You have a very difficult job and you're doing it very well under very difficult circumstances, and we're very grateful for that. And I'll stop there. Thank you.
Thank you very much, Professor Mutapi, for these kind words for WHO. I think this closes the media briefing. I would like to thank all our panelists for the time.
Hello.
Yes?
Are we letting Chikwe say a few last words?
Dr. Chikwe unfortunately left the meeting. He said in the chat that he had to go. Yes, I should have mentioned that, sorry. Yes, he told us in the chat that he had to go, and so we have no message from him. Unfortunately, he didn't leave a message in the chat for us. That's why I would like to close now the media briefing and thank all the panelists for the time, thank our interpreters as well, and wish you all best wishes for the new year and keep safe. Bye-bye. Thanks you to the journalists as well for being there and for their questions. Bye.